Hi, Sriharsha. Can you hear my voice?
Yes, sir. Can hear you.
I- Is my voice clear?
Yes, sir.
Perfect. All right.
So I welcome all to our webinar series on OSA. So last week we started off on upper airway resistance, and this is our second meeting. Today, Dr. Vikas Agrawal will be speaking about all about sleep study levels. So most of the postgraduates are really confused about levels of sleep studies, what kind of sleep study should we order, and I'm sure a lot of young ENT consultants also would be benefiting from this webinar. So I would like to briefly introduce Dr. Vikas Agarwal sir. For those who have joined for the first time, he is the past president of Indian Association of Surgeons for Sleep Apnea, and he's the chairman and committee for sleep disorders for the IAOHNS. He has also released Indian guidelines for sleep apnea surgery as the president during his tenure, and he has formulated various consent forms, and he's the first Indian surgeon who has performed robotic tongue-based surgery, and also he has telecasted this a lot of surgeries. He has a YouTube channel which showcases a lot of his sleep surgery works, and he's given a lot of orations in various annual conferences in India as well as the rest of the world. With this short introduction, I would like to welcome sir. Sir,
Thank you.
good evening and welcome back.
Good evening.
I'm sure a lot of
Thank you,
people are
Sriharsha.
eager for the presentation and as well as to watch the cricket match. So,
I know. So
yeah,
we'll finish it really fast.
yeah, yeah, sure.
We did not anticipate that today was a match. We would have kept it on another day. But now, since we have already announced, let's do it. So without wasting time, let me share my screen.
Sir, your video is
Continue.
also off.
My video is off.
Yes, yes, yes.
Uh, see,
Yeah, yeah, you're visible.
it's on. All
Mm.
right. And is my screen visible now?
Yes, your screen is visible, but your presentation is not yet.
All right.
Yeah,
So
now,
just let me know.
yeah, you can start, sir.
All right.
Mm.
All right. So today we'll try to finish it off really fast because of the match, but I'll try to simplify the sleep study, which a surgeon should know. Actually, it's so complicated that it really gives a very bad feeling to a new person who enters this field. And as surgeons, we know we have to simplify things so that we can take decisions and do the work rather than just talking academics. So, thank you one and all for joining. And once a patient comes to you in your clinic with symptoms of snoring, daytime sleepiness, then how do you diagnose whether this person has got simple snoring or sleep apnea? So, obviously, you do a polysomnography test. So, once you have a patient whom you suspect some sleep disorder, whether it is sleep apnea or not, whether it is snoring or not, whether it is some other kind of 84 kind of sleep disorder, you have to do the sleep study. So, why do you do a sleep study? To know whether it is a sleep disorder or not. Whether you are dealing with a sleep disorder or something else, you have to have some evidence if you treat a sleep disorder. So, that is the basic thing for which you do a polysomnography. Second is whether it is a sleep related breathing disorder or any other kind of sleep disorder, such as narcolepsy, restless leg syndrome. So, whether it is a sleep related breathing disorder, which includes simple snoring, upper airway resistance, and obstructive sleep apnea, or some other kind of sleep disorder, you still have to do polysomnography to know what are you dealing with. And third is what is the magnitude of the problem. So, whether it is a sleep disorder or not, whether it is a sleep-related breathing disorder or not, and then what is the magnitude of the problem. So these are the three reasons why for which you will do a polysomnography. Unfortunately, a typical polysomnography involves a lot of measurements. So obviously, pulse oximetry in the finger pulse is very common, very easy. But then you also need to know whether the patient is sleeping or not. So you need to do EEG, which will give you brain activity. Then you have to do EOG, which will tell you whether the patient is having rapid eye movement or not. That means whether he is into REM sleep or not. Then you have to measure airflow to know whether it is apnea, hypopnea or not. And airflow, obviously, you have to have airflow sensor. Then you have to do EMG to know what is the muscle tone, chin EMG. Then you have to have the microphone for snoring sound, ECG for the heart, thoracic belt for abdominal chest expansion, and abdominal belt for the abdominal expansion. If you have so many things, then you can diagnose everything, and this is the basis of a typical level 1 polysomnography, which is the gold standard. Unfortunately, with so many things attached, it's very difficult to sleep. First of all, the machine becomes bulky, that so many wires attached, the person finds it difficult to sleep with so many wires attached. And then you have to have a technician, then you have to have all the recordings, then you have to manually score the sleep study. So the thing becomes costly, it is not easily available. And though it is a gold standard, but obviously gold is scarce. So level 1 polysomnography is also scarce, right? And then nowadays they are also adding video cameras so that you see what exactly is happening. So if you have a level 1 polysomnography with video cameras, then obviously it is even more good, but then becomes more difficult, more costly, and everything. And as I said, sleeping with so many wires around is a difficult job. So let's understand what levels are there and how you interpret them. Now, first of all, the sleep study itself is difficult because of so many wires. Now, if you look at the tracings, now given this graph, anybody will be perplexed because it's so difficult to learn all these alpha, beta, gamma, theta waves, and in all the EOG, EMGs, then ECGs and thermistors, thoracic movement, abdominal movement. All these things become really very difficult to, understand and learn. I understand there are a lot of basics that you must understand, but how to simplify it? So you can simplify something only when you understand the basic, without going into too much of detail, at least what are the basic things in a sleep study. So in the next 7, 8 slides, I'll very basically try to give you the gist of what a sleep study is all about, and then try to simplify it further. So now this is the tracing and this is the report. Suppose if this is the report in front of you, can you make out anything? It's so very difficult, so much of data around, you really cannot understand. So what I'll do is, though it is, every bit of it is very very important, nothing is without importance, and if you go step by step, you will learn everything. Here it is the sleep parameter, here it is the arousal number, periodic limb movement, cardiac parameters, respiratory parameters. But let me break it down into simplify and try to make you understand that how you can read a sleep study in less time and the important parts of it, right? Because if you try to go through everything, then you'll not reach anywhere. You can go back into the thing when you require a particular information. After going through the basic, if you require a particular information, then you go into the chart and read that particular thing to know what exactly is happening. But let's try to make this wire straight first. So a diagnostic report, let's first understand what is AHI, apnea hypopnea index. Till today, this is the most important index that we have to know about sleep study, which is the total of all scored apnea and hypopnea. What is apnea? Complete stoppage of breath for more than 10 seconds. And hypopnea is reduction of breath for more than 10 seconds by 30 or 40%, divided by the total hours of sleep, right? So if their total number of events is around 80 and a person has slept for 8 hours, then the AHI would be 80 divided by 8, which is 10. So AHI would be 10. What is RDI? Respiratory Disturbance Index. So now this is total of all apneas and hypopneas, AHI plus RERA, respiratory effort related arousal. So how many times, because of the respiration, there was an arousal that may or may not be associated with apnea or hypopneas. So the oxygen saturation will not drop, but still there will be arousal. If that is added to the AHI, which is hypopnea and apnea, which is desaturation, if there is no desaturation, but still the patient has been awakened up by his own breath, that is respiratory effort related arousal. So if that number is added to the AHI, then we call the total thing as RDI, respiratory disturbance index. And there I have already explained, when there are 10 seconds or more of increasing breath effort or flattening of the pressure wave, flow waveform. Total sleep time, obviously how much was the time that the patient spent in N1, N2, N3 and REM sleep. There are 4 stages of sleep: N1, N2, N3 and REM. So what is the total sleep time? What is total recording time? So lights out to light on. Total time in bed. So you will see all these things: TRT, TIB, time in bed. So these are very simple things. Time in bed, TIB. What was the total time patient spent in bed? Lights out to light on. Total recording time, how much time you recorded the thing, and total sleep time, how much was the patient actually sleeping. And wake after sleep onset, this you can possibly mark. So now, polysomnography report, the first page will show the patient name, uh, his male or female, birth date, age, height, his weight and height, then BMI, how much is the BMI, neck circumference, recording technician code, this and that, and the duration of sleep, weight of the patient, Epworth Sleepiness Scale, referring physician, etc. The second page will generally show you how much of the latency was to from the lights off to N1, N2, N3, and REM. What was the duration of time in bed, sleep time, total sleep time, REM time, non-REM time, sleep efficiency. So how much of the percent of time the patient slept, total, you may not go into everything, but then you can see how much of the sleep stage distribution, how much percentage of total sleep time the patients spend in N1, N2, N3, and REM sleep, like that. If you want to go into detail, you can go later on. So these all things are given there. Now, this part is very important. This is CA is central apnea, OA is obstructive apnea, MA is mixed apnea. Now you see this patient, his has got 3 apnea and 58 hypopneas. Total apnea plus hypopnea is 61. Now his sleep time is around 5 hours. So his index is around 12. But out of this 12, his apnea index is only 0.6. His hypopnea index is 11.8. So out of 12.4, it is majorly hypopneas, right? So this patient is not having an apnea. So what I will think from this, that this patient may be having a bad nose block because he's having more of hypopneas. So though his AHI is 12, but his AI is only 0.6. So this is something very, very important to note, that how much is the in the apnea plus hypopnea, what is the component of apnea and what is the component of hypopnea. This is the most important thing for a surgeon to understand. And then how much is the REM index, how much is the non-REM index. We see here that during REM, his AHI is 7.4 and non-REM is 13.2. That means it's not a predominantly REM problem, it's a whole night problem, and it has to be tackled, right? Now, on the other page, you'll see the oximetry. So, what is the average saturation of the total sleep time, total sleep in bed? How many desaturation? Here, the desaturation is only 2. Desaturation index is only 0.3. So, obviously, this is not a very severe patient. It's a very, very, mild patient. This I'm just giving you an example. What is the total leg movement? Here, the total leg movement are whether it is significant or not. So, this will give you an idea whether this patient's sleep is disturbed because of his leg movement or not. Then last is the body position summary. If you see that this patient here, it is mainly non-supine. His sleep is, he has spent a lot of time in non-supine position and only 19.4 in supine position. Now you see he has spent on the left side he has spent 205, and on the right he has spent only 70, and his AHI is maximum on the right side. That means he would be possibly having a deviation of the septum towards the left. That because of that reason he is getting a difficulty in sleeping on the right side. He is comfortable sleeping on the left. His AHI on the left is only 6.2. So if somebody has a deviation on the left side, he'll sleep easier on the left and more difficulty on the right. So this is what I can possibly think only from the sleep study also. And then you have the cardiac summary and cardiac event. You can see how much bradycardia, pulse rate, maximum, minimum. So obviously this is not a very bad patient. And then you can have a hypnogram, stages of sleep, heart rate, oxygen saturation, everything you can see on this hypnogram. So this is in very short about how a sleep study report would look like. Now, this is level 1 sleep study. So obviously the problem with the level 1 sleep study is that you have to have so many wires around, and then there has to be a technician, there has to be a reporting. Manual is better, automatic will not give you that much of good result in polysomnography level 1. And you have to sleep in a sleep lab. Then there's the first night effect. You go to a hospital, you go to a sleep lab. The bed is not of your choice, of your liking. You cannot sleep well. It's a foreign place, so again you do not you're not comfortable. So then the same thing, if done at home, if polysomnography with all these leads are done at patient's home with the technician who can attend it, who can be in the same room or can leave it unattended, you call it level 2. But again, the same number of wires are still there. So if you do only a limited study, which is cardiorespiratory study only, whether you do it at a hospital or home, then you call it level 3 study, which is the most common study done because the number of wires are less, the cost is less, easily done. Most of the time, there is a automatic reporting. That's called level 3 study. And level 4 is a pulse oximetry only or a peripheral arterial tonometry. You can see now there are a lot of devices, watch pat and night owl and all those newer things which are coming are level 4 devices, which are like they are trying to make it the standardized like level 3, but they are still a level 4 device because there you do not measure the apnea and the hypopnea with breath. It's only based on the peripheral arterial tone or pulse oximetry. We call it level 4. So I hope you have understood what is level 1. Level 1 is the full gold standard with all the leads where you look for EEG, EOG, EMG, heart rate and full cardiac data, ECG, and along with cardiorespiratory. The same thing at home is level 2. Only cardiorespiratory data, whether at home or hospital, is level 3, and only pulse oximetry or peripheral arterial tonometry is level 4. So this is the most simplified version of understanding. Now, which one should we advise? Should we advise level 1 to everybody? Obviously not. So which patient should be advised level 1, level 2, or which patient should be advised level 3? That we'll discuss. So if we are not sure that the patient is having sleep-related breathing disorder, that means if it is a garden variety sleep apnea that the patient is snoring to glory and the bed partners has witnessed the apnea, then obviously you conclude the pre-test probability of having a sleep-related breathing disorder is very high. In that case, you can advise a level 3 study. But if you're not sure, if the patient says that I'm not fresh, but I cannot sleep, it is insomnia, or he says that I do not snore, but still I'm not fresh. Somebody would say that I, get up in the sleep walking, sleep talking, and somebody would say that I move my leg a lot, but I do not snore. If you're not sure about sleep related breathing disorder, then you have to advise level 1. So if you're not sure that you are dealing with a garden variety sleep related breathing disorder, then you must advise level 1 polysomnography with all the brain waves and everything, because it will tell you about all the parasomnias, all brain waves, restless leg syndrome, narcolepsy, etc. Everything will be taken care of by one sleep study, and you would not have to repeat this study again after doing a level 3. So straight away go for level 1 sleep study. Now, if your patient has complications like ischemic heart disease, COPD, etc., and if there are too many things, some liver issues, diabetic, uncontrolled hypertension, then you should definitely go for a level 1 polysomnography, because you want every small detail, and every small detail will be required for this patient. However, if this patient cannot tolerate, cannot sleep with all the leads, then you will still be constrained to do a level 3 study first. But primarily complicated patients and unsure patients, you should be doing a level 1 polysomnography, a proper sleep study in a lab, or at least a level 2 study at home. So at least you get all the parameters, right? Now, if you have a very, very clear suspicion of sleep related breathing disorder,
Excuse me, sir. Can you share
yeah,
your screen, sir, once? It got disconnected.
all right, all right. I'll share the screen once again. Continue, share screen. Let me know if it is coming now.
Y- Yes, sir. Yes.
Coming? All
Yeah.
right. All right. So should I go back to the earlier slide?
Yes, sir. Just one slide back, sir. Yeah.
This is fine.
Yes, yes.
All right. So if we are not sure that we are dealing with a patient of sleep-related breathing disorder, and we suspect some other sleep disorders such as restless leg syndrome, narcolepsy, parasomnia, insomnia, sleepwalking, sleep talking, and all those 84 kind of sleep disorders, then we should be advising a level 1 polysomnography with all the brain waves and all the details. And if the patient is having ischemic heart disease, COPD, uncontrolled diabetes, blood pressure, then we should be advising level 1 polysomnography. But if we are very sure that the patient is the garden variety obstructive sleep apnea and snoring and sleep related breathing disorder, then we can advise level 3 study, because it's easily available and it's cost effective. And the patient does not have to sleep with so many wires. You can see there's only a nasal cannula for the nasal breathing, there's a chest belt, and there's a pulse oximetry. So the breathing effort is taken care of by the chest belt. The apnea hypopnea is, taken care of by the nasal cannula, and the oxygen saturation is taken care of by the pulse oximetry. So these are the only parameters used in level 3. So we all prefer level 3 in majority of the cases of garden variety sleep related breathing disorders. Now, what is the limitation of level 3 study? Once we understand the limitation, then we know that which patient is a good candidate for level 3 and where we should be doing level 1. So, the limitation of level 3 is that you may underestimate the problem. How you can underestimate the problem? Now, here I've shown you the tip of the iceberg. So, you're thinking that the problem is only this much, but there's much, much more below the surface of the water. So how you underestimate the problem in level 3 study, I'll explain you. Suppose if your patient was in bed for 8 hours and you recorded the sleep study for 8 hours, but you have not recorded the brain waves and the patient did not sleep for 4 hours. So in effect, what you have got, you have recorded for 8 hours and say you recorded 160 events. So the AHI you calculated was 160 event divided by 8 hours is 20. But the patient has actually slept for only 4 hours. So his actual AHI should have been 160 divided by 4 is equal to 40. That means you have interpreted the AHI as 20, say a moderate sleep apnea, but actually he's a severe sleep apnea patient, right? So this is the limitation, because if the patient has not slept, you do not know because you have not measured the brain waves, right? So this is one of the limitation. However, you can circumvent this by seeing whether the patient was snoring in that period or not. If a patient was snoring in that period and still there was no hypopnea apnea, then you can be reasonably sure that the patient was sleeping and still he did not have hypopnea apnea. But this is again not very confirmatory. So this is one of the limitations of the level 3 study that you should remember. But so false negatives are possible if you get a sleep study which is normal. it is still possible that the patient may be still having, because he did not sleep only the whole night. You'll get a false negative sleep study because you have not measured the brain waves. But false positive is not possible. You can never overestimate. If you have got a AHI of 40, then it is not possible that the patient, it was 20 and you have estimated at 40. If something is seen, definitely that much is there for sure. You can underestimate, but you can never overestimate. So there's no false positive in this. If you see something, if there's a ghost, that means there is a problem. If in level 3 study, if you find it positive, that means the patient is a case of obstructive sleep apnea for sure. This is what I wanted to impress, that you may underestimate, but you will never overestimate. So you can do this study. If you get a negative study, you may repeat it. But if you get a positive study, the HI should be only higher. It cannot be lower, right? So this is a most very, very important observation that you must carry. It misses out on RERAs. Obviously, if the patient has, the saturation has not dropped, the apnea, hypopnea has not happened, so respiratory effort related arousals you'll not see in level 3 study, you will see it in level 1 study because you are checking on the brain waves. So this is the second thing, that if the patient is having a nose block issue and if you do a level 3 study, so obviously the study may come just normal because the RERAs, the patient is not fresh because of his arousals, but you will miss it out on the level 3 study, right? Now you have done a sleep study. Level 4 study, I have not purposely gone into. Level 1 and level 2 are almost similar. Level 3 and level 4 I have not gone into because it is not standard. Level 3, at least you know apnea hypopnea index. Level 4, you do not even know apnea hypopnea index. The way they calculate is still not standardized, so I will not get into detail. That is a screening device which tells you whether the patient has got sleep apnea or not. But you cannot really calculate whether it is apnea or hypopnea because you're not measuring apnea and hypopnea. So I'll not go into level 4. So now you have done a sleep study. What information will you get? And is it enough to cure the patient? Because we are surgeons. We are doing a study to cure the patient. So the information we will get, most important information we will get out of all is the AHI, right? Less than 5, we consider normal, 5 to 15 mild, 15 to 30 moderate, and more than 30 severe. This is everybody's last 40 years, this has been taught to us. Now, how important is this? This was something made around 30, 40 years back by a group of doctors sitting in a room, and that criteria was given. So it's a very old thing. It is still continuing, but we need to definitely understand what does it mean. So what is AHI? Apnea and hypopnea index per hour. How many events of apnea and how many events of hypopnea per hour? This is AHI. Now, what is apnea? Apnea is a complete stoppage of breath. Somebody has completely, your throat is completely collapsed inside. There's no oxygen exchange happening. There's no air transfer happening between the upper airway and the lungs. That is apnea. Complete stoppage, 100%. Whereas hypopnea is just a reduction of breath. Now, how they two can be equally important, I fail to understand. So earlier it was apnea index only. Later on, hypopnea index was added to it so that lot of patients could be brought into the, uh, into the definition of sleep apnea. And my belief is that it was majorly to, promote a CPAP, uses. It was influenced by that. I'm sorry to say it on a public platform, but this is my observation, my understanding, that apnea is very, very important. Hypopnea is not so important. Hypopnea is obviously, if you breathe less and oxygen is going less, in longer term it will also affect your health, but not as bad as an apnea, and you cannot equate it. You cannot have an equal weightage of it. Unfortunately, the AHI is giving equal weightage to this, and that's why I'm making this statement. So apnea is 100% block for more than 10 seconds associated with desaturation. Hypopnea is 30 to 40% reduction in the airflow for more than 10 seconds associated with desaturation. Now, if somebody is only breathing shallow and his saturation is only dropping by 3 to 4%, and somebody is completely choked and his oxygen is dropping by 40-50%. These are two different things. So when your desaturation is more than 3 to 4% associated with apnea or hypopnea, for more than 10 seconds, you call it one event. Now, more than 10 seconds. More than 10 seconds is 11 seconds also. More than 10 seconds is 1 minute, 60 seconds also. It's 2 minute, 3 minute, 180 seconds also. Till the person dies also, it's still one event. Whereas if somebody is having an oxygen saturation of 96% for more than 10 seconds with a 30% reduction in the airflow, that is also one event. Now, if we take it theoretically, if somebody is having a long apnea of 2 minutes, right, and he breathes for 30 seconds normally, so his each cycle is 2 minutes, 180 seconds plus 30 seconds, 2.5 minutes. How much AHI he can have? Divide 60 divided by 2.5. His maximum AHI can be only 24, but he's a very, very severe patient. This is a theoretical situation I'm telling you. And if somebody has a hypopnea of say 10 seconds and he breathes for 5 seconds, so in 1 minute he'll have 15 seconds into 4. So theoretically he can have AHI of 60 minutes divided by 4 into 4 per minute. He can have a AHI of 240, but he's absolutely, his saturation is always above 90. So theoretically, if somebody has a hypopnea of 15-second duration, 10 second plus 5 seconds of breathing, he can theoretically have AHI of 240. And if somebody has an apnea of 2 minutes and 30 seconds of breathing, he can have AHI of only 24. So obviously, this is a very, very simplified version, and this is not correct. Therefore, you cannot just go on, deciding on AHI. And this is why I'm telling you this thing in this manner so that you understand that you have to understand what is apnea, you have to understand what is hypopnea, and then go through this sleep study and understand how severe is the patient. Second, suppose if your AHI is 30, 40, you know that it is a severe patient or 100, but it will still not tell you what is the cause, whether the cause is in the nose, the cause is in the soft palate, cause is in the base tongue, or the epiglottis. So how you will treat this patient? So AHI is good to know the severity, but it will still not tell you what is to be done. So as a surgeon, it's not of much use to you. And in AHI, uh, done on the level 3 study, if you do not use the RDI in upper airway resistance syndrome, again AHI is negative. So AHI has its own limitations. So what is, when you include the RERA, then you get the RDI, as I said, respiratory disturbance index. So this is normal breathing, no disease, snoring. And from here, upper airway resistance syndrome, that means no apnea, hypopnea, only sleep is disturbed. In the last lecture, I said that it's like mosquito bite. Your sleep is disturbed, but your oxygen saturation is not dropping. There's no the cardiopulmonary, there's no disturbance. It's only the neurological problem. That is RERA. So obviously, if you use the RDI will be much higher, including the RERAs. And if you only use the AHI, then mild, moderate, or severe sleep apnea. This is AHI versus RDI. So as I said, apnea of 40 seconds with the desaturation of 50% and hypopnea of 10 seconds with a desaturation of 4% has the same weightage on the score. Obviously, this is not correct. This cannot be, you know, this cannot be the same, but unfortunately, this is how AHI is as of today. So if you see this is apnea, complete apnea. Patient is trying to breathe, but is unable to breathe. And you can see oxygen is already, saturation is dropping. Already half a minute. Patient is trying to breathe, is unable to breathe. Complete apnea. Oxygen further dropping, is unable to breathe. Now a small breath has gone inside. Oxygen has gone Now there's a breath. So you can see almost 1 minute apnea. This was 1 minute apnea with the oxygen saturation going on to 50, 60. This is an apnea. Now compare it with hypopnea. The patient is breathing less. His oxygen is not really dropping too much. It's in the range of 90, 92, and the patient is breathing lesser. That's hypopnea. But the air exchange is still happening, oxygen exchange is still happening, airway is collapsing, but not completely. This is hypopnea. The second thing is AHI again does not give you any about the site of obstruction, as I said earlier, or obstruction. So how will you decide what surgery is to be done? Now, one patient's apnea was at the palatal level here, below pharynx, and this patient is having an obstruction at the base tongue level, complete collapse of the base tongue. Now, palate surgery and base tongue surgery are two different ball games. So here it is the base tongue and epiglottic collapse. So palate surgery is a totally different ball game, and the base tongue surgery is totally different ball game. Other patient is having simple hypopnea. And you see base tongue is not collapsing. And you know that this patient will even respond to CPAP. So again, this is a different patient. So this is how you have to understand that AHI gives you a rough idea about that, whether the patient is having, what is the range of this patient's problem. That's it. Beyond that, you as a surgeon, you do not get much idea from the AHI. Now, you have to see whether apneas are more or hypopneas are more. So look at the apnea index and the hypopnea index separately also. Do not only look at the AHI, because if it is apnea, then possibly the pharyngeal problems are more pronounced. You'll get more problems in the palate and the base tongue. If it is AI is more, whereas if it is only HI which is more, then you might be dealing with a nasal obstruction only, because there is only hypopnea. It's only reduction. It's not a complete stoppage. Complete stoppage will generally happen only in the pharynx. But what happens is that because of a gross obstruction in the nose, you can still have a collapsing effect in the pharynx. So obviously that part is to be taken care of. But you have to understand that if it is predominantly apnea index, then you certainly expect a problem happening in the soft palate, base tongue, epiglottis. If it is predominantly a hypopnea, then you expect a problem to be happening in the nasal region more than the pharyngeal region. Then it also does not tell you about the difficulty in intubation extubation. Now, this is again a very, very important aspect. If I have a patient of AHI 100 versus a AHI of 30, should I be very happy that, oh, this patient is only AHI 30, other patient is AHI 100? Not really, because AHI does not tell me the level of obstruction. So it does not tell me the difficulty in intubation extubation. See, the difficulty in intubation, I cannot, there's a whole chapter, a whole talk on this, but let me just tell you in short that if somebody's AHI is 100, but the problem is in the upper segment. So, what is upper segment? There's nothing defined in the literature. This is my own definition. Upper segment and lower segment. The upper segment is nose and the nose, nasopharynx, and the velum. That I call the upper segment. And lower segment is the base tongue and the epiglottis. So, if somebody's problem is only in the upper segment, when you try to intubate, you put an oral airway and you bypass the whole upper segment. So whether the AHI is 100 or 30 or 20 doesn't matter. If the base tongue is not large, you put an oral airway, you'll be able to easily intubate, ventilate, everything, right? Extubation depends more on the BMI, and this segment of extubation does not on the AHI. So AHI again does not tell you the difficulty in intubation, extubation, because that depends on the upper segment or the lower segment. If the AHI is 20 with a predominant lower segment block, you will still have difficulty in intubating this patient. Whereas if the AHI is 100 with upper segment block, you can intubate and extubate this patient much easier. Now, this is a patient of AHI 70 in which the AI is 60, apnea index is 60, hypopnea is only 10, and majorly apneas, but you can see the base tongue is not affected. AHI is 70, but the base tongue is not affected. So obviously in this patient, I'm not expecting any difficulty in intubation, extubation, because this patient is amenable to CPAP also. So that also gives you an idea. If this patient is having AHI 70, but he can tolerate CPAP, then possibly the intubation, extubation will be easy. I can always ventilate this patient because he can tolerate CPAP. He can sleep with the CPAP. Whereas, so obviously you can look into it, and if the lower segment is not a problem, AHI 70, 100 really does not matter because you can still see the larynx and intubate this patient. Whereas if the tongue base is bigger, then you'll have difficulty in intubation and extubation. Now this patient, AHI is 45, that patient AHI was 70. This patient's AHI is 45, but see the tongue base, huge tongue base. So you know that the moment this patient will lie down and he will induce sleep, he'll be totally obstructed, completely obstructed. So AHI doesn't matter here. His AHI was 70, this guy's AHI is 45, but this is a much, much more difficult patient, right? So this segment is more important than the AHI. Now, once it is the tongue lower segment, in lower segment also, the tongue has got two parts, anterior two-third of the tongue and the base tongue. So the anterior two-third of the tongue does not contribute to obstruction at the back of the tongue. It is only the base of the tongue. So intubation, extubation are decided by the base of the tongue, not by the anterior two-third of the tongue. Anterior two-third of the tongue decides the Malampatti classification. So if you see that the tongue is large, Malampatti wise, but still if the base tongue is not large on the dice, you can still intubate, extubate this patient much easier, because if you use a true view laryngoscope or any video laryngoscope, you can easily bypass the anterior two-third of the tongue, and you can lift the base of the tongue and intubate this patient, ventilate this patient if the patient does not have a base tongue obstruction, right? This is the way you can visualize. You only have to bypass it by the video laryngoscope. Whereas this is how you can bypass. Whereas if the patient has a base tongue obstruction, even with the video laryngoscope, the base tongue is also affected. So you'll have to go right till the base tongue and then lift and then intubate, because this patient whose base tongue is large will get desaturated very fast. If the anterior two-third of the tongue is large, he will not get desaturation very fast. And now see, epiglottic collapse AHI is only 10. So it's a very deep thing, epiglottis, base tongue epiglottis, but the AHI is only 10. So you have to do a much difficult surgery, epiglottic surgery, but the AHI is only 10. So AHI does not tell you the difficulty in intubation, extubation, what surgery you have to do, what is the expertise required, equipment required, intubation complications which can happen. AHI doesn't tell you any of these things. So in short, we understand that this is how the simple snoring, AHI is 0, upper airway resistance syndrome, AHI is 0, 0 to 5, mild OSA is 5 to 15, moderate to 15 to 30, severe is more than 30. Now more than 30 can be 100, 200, 300. So that is again a very, very false thing about AHI. And then obesity hypoventilation syndrome. I'll not go into detail, but if the BMI is very high and the desaturation even when awake, then you call it obesity hypoventilation syndrome. And these patients have a CO2 retention. So you can have a combination of severe AHI, severe obstructive sleep apnea, and obesity hypoventilation syndrome. So you have to pick up which is only a severe obstructive sleep apnea and which is a case of obesity hypoventilation syndrome. In these cases, you will see the CO2 retention and bicarbonate high. Now, if you have a sleep study report at a glance what all you will see. I have already explained you in detail about AHI and RDI. I have already told you about the RERAs. BMI is very important because if the BMI is high, your patient will, have more oxygen, more CO2 retention, He'll have more accumulation of the gases in the fat, which will release in the post-operative period. His, reserves for oxygen will be much lower because his demand will be more. So you must look at the BMI more importantly than the AHI. Now, minimum oxygen saturation. If you're doing dyes, if you're doing surgery, you have to know if the patient is, some patient is used to a 60% saturation. His minimum is 60, and every now and then his saturation is touching 60. So you can easily let the patient desaturate to 60, 70, no problem, because his body is used to it. But if this some patient is only touching 80, 85, and you take him down to 50, then obviously this patient can develop all these problems of cardiac and all those arrhythmias and everything. Because if you desaturate him too much, then there can be a problem. Now, another thing is the time spent below 90% saturation. This is a very, very important thing, that if the patient is spending a lot of time below 90% saturation, then his cardiac functions, his hypertension, and his all the parameters, his body will react very, very badly to it. But if the patient is having more than 90% saturation throughout, and only occasionally he has gone below 90 to 85 or 86, then he is definitely not a serious patient. So this time spent below 90% saturation is a more important factor than the AHI again. Body position during sleep. As I told you, if somebody is only having supine apneas, only supine apneas, there is no apnea in the lateral position, then why you want to do a surgery? Why you want to give him CPAP? Just give him a positional trainer device, or you give him a tennis ball in the pajama so that he does not sleep supine. He sleeps on his side, and the problem is solved. You do not need to do either a surgery or CPAP. If somebody is having REM apneas only, then what will you achieve? It's only during the REM time that is he's having the apnea. So you'll not achieve too much by operating on the REM apneas patient. And there are some patients REM apneas. Now let me show you here. See, this is the REM apnea. Can you see the top one? Sorry, sorry. This is the REM. Only during REM sleep, you can see this, my pointer. Only during REM sleep the patient is having apneas. Rest of the sleep, he is not having apnea, hypopnea, his heart rate, everything is fine. Only during REM sleep, he is having snoring and hypopnea, apnea only during REM sleep. His oxygen is saturation is dropping only during REM sleep. What will he achieve by doing any surgery on this patient? Right. So we have to see why his REM is so pronounced. So let him sleep not in the supine position, let him sleep on the sidewise thing. And if it is a purely REM thing, then you have to treat him with CPAP. You may not achieve anything by doing a surgery on this patient. Right? So this is the REM, 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 and REM. And all the apnea hypopneas are during REM sleep. So this is a very common finding, which I see that people operate on such patients, and obviously the patient does not improve. Now, before we part, a word about pediatric sleep study. Honestly, I'm not a great fan of pediatric sleep study. I do not do it routinely because it's very difficult for patients to sleep with all these, things attached. And I simply do a tonsil adenoid surgery or a base tongue lymphoid tissue excision if required. And if that fails, in those cases, I definitely look for a sleep study. So, the indications of pediatric sleep study, very small kid, if he's got having no tonsil adenoid in and is having sleep apnea, then there could be some issue with the muscle tone, then I would do a sleep study. Very obese child, Down syndrome child, craniofacial abnormality child, because we need to know each and every detail of this child. Neuromuscular disorder, 100% are not surgical candidates. They are a good candidate for pediatric sleep study. Sickle cell anemia, mucopolysaccharidosis, congenital heart disease, uncertainty, about what is the diagnosis, same as adults. Physical examination is not supporting a finding, you know, other surgical anesthesia risk, and certain other situations, I would do a pediatric sleep study. Otherwise, I will not do a pediatric sleep study. Now, if you do a pediatric sleep study, the difference is that in an adult, AHI more than 5 is significant, but in children, AHI even more than 1 is significant. Right? So this is the difference, more than 5 in adults, more than 1 in children. And minimum oxygen saturation, generally in adults, less than 85 is significant. In children, just the moment it touches 90, it is significant. So obviously children are more, resilient. to sleep apnea. So this is what you have to keep in mind. And in interest of time, I would stop my presentation here. And I would. Are you uh, are you able to see me or still seeing my screen?
We can see you, sir. We can see you.
All right, all
So,
right. So I think it's 45 minutes, or a little more than 45 minutes. So I'll will try to finish it early, and let's take the question and answers. Hope it was understandable to people.
sir, yes. So, as of now, there are no chat questions posted yet. I think people were
Mhm.
anticipating a little more lecture from you, sir.
No,
So,
as I said, because of the match, I tried to finish it little fast and earlier.
so
So,
I've opened up the unmute option. So anybody who wishes to take questions can unmute and
yeah, I can see a lot of logins.
yeah, there
A
were
few hundred. I can see a few hundred logins at least. So I'm open to question. I have not uh, taken it too long, so that. But Sriharsha, did you understand that
yes,
when
yes,
to order which kind of sleep study and what to
yes,
expect?
yes, yes. I've
Because
learned.
it's a very confusing topic.
Mm.
Very clear and many doubts solved, Dr. Chaudhary. Thank you, Dr. Chaudhary. Manya, it was nice. Children and education. I think now you can take questions. People are writing questions
Yeah,
now.
yeah, now they're posting questions. Can't unmute. Why can't you unmute? Oh, sorry.
Rahul is asking
Yeah,
what.
I've enabled unmute option now. Yeah, sorry, I've enabled the unmute option. Now you can unmute. So,
Hi.
Dr.
Hello, sir.
Rahul,
Good evening,
what
sir.
parameters on level 3 diagnose upper airway resistance?
Yeah, so as I said, you do not really see the parameter in the level 3 study because whereas you really do not see. But you'll see that there's a lot of snoring and uh, you know uh, the patient AHI will not obviously be clear on level 3 study. The RERAs will not be clear on level 3 study, but you'll see a lot of snoring on the level 3 study. And if the patient, this is one of the limitations. So you'll have to, if you want to document it, either you do a level 1 study or you do what we call the apnea graph. I used to do apnea graph from 2010 to 2016. Then I abandoned using it because it was, you had to put a probe inside. That is the most confirmatory study for upper airway resistance syndrome. But level 1 RERAs, you have to really go for level 1 if you want to document the RERAs.
So, next question is, can you once again explain about RDI and RERA?
All right. So, see, apnea, hypopnea index, and respiratory disturbance index. These are the two indexes. So, what is apnea hypopnea index? The number of apneas and hypopneas in 1 hour is apnea hypopnea index. Now, if you add to it the respiratory referred effort related arousal, RERA, number of RERAs in 1 hour, if you add to it, then it becomes a RDI. So obviously you cannot get RDI into properly into level 3 study. You'll get a proper RDI into level 1 study. Got it? So if a person's sleep is disturbed, you can pick it from the brain waves, but his oxygen desaturation has not happened. That is RERA. All right. So once you add RERA to AHI, it becomes RDI. Is it clear?
Yes, sir. So, so anyway, I think you have spoken about the relation between AHI and surgery. There's one question, sir.
Yeah.
Is there any cutoff for surgery?
No, 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 no. I have operated on my highest AHI that I have patient that I have operated was 140. 140 AHI. As I said, the AHI number has doesn't mean anything.
Doesn't mean anything. Yeah.
It's Yeah, it says that the patient is having a severe sleep apnea. See, AHI 100 and AHI 10, 15 cannot be equal.
Hmm.
Correct?
Hmm.
There is a gross difference. If somebody is having AHI of 5, 10, 15, and if somebody is having AHI of 100, but it is more of a function thing. It's not of anatomy,
Hmm.
right? So if somebody is obese with a very less obstruction, he'll have a very high AHI because his oxygen dissection will be many more times. If somebody is thin with a very bad obstruction, he may still have a very less AHI.
And one more question, sir. Like, when do you feel you have to repeat a sleep study? Like, for example, the first study was done yesterday, and uh, are there any parameters where you feel that this study has not been properly conducted, or the results are inadequate?
Very, very nice, very good question. So see, if in a level 3 study, as I said, you can have false negative.
Yes.
If your suspicion is very strong and the patient is coming with a very low sleep study results, or and you see that the pulse oximeter is not working for 2 hours, there was no pulse, the pulse data was not present, or if you see that the nasal prong there was no air exchange during that time, that means the nasal cannula was removed, then obviously you'll repeat a sleep study. If you are not happy with the results, you are expecting a AHI of 100,
Hmm.
80,
Yeah,
90,
it
and
has
you are
an
seeing
impact
AHI of 5, 10,
on.
then you will obviously do a level 1 study and confirm it. But if you are expecting AHI of 70, 80, 100, and if it is coming at AHI 60 or 50, I would not repeat the sleep study because anyway, that doesn't make a difference to me anyways.
Hmm.
Yeah.
And
So these are the two things. If you see that the prongs were removed, the data is not correct, then 100% you'll have to repeat the sleep study.
one more dilemma is, when do you repeat the sleep study after surgery?
So there's no dilemma about it. Honestly speaking, why do you first of all you want to repeat the surgery after sleep study after surgery?
Most of the time,
One is to
patients demand.
absolutely.
They are
So
curious.
that's what I'm saying. In that what do you see AHI again?
Mm.
So if the AHI has gone down, both of you are happy. If AHI is not gone down, the patient was happy before, and now he'll not be happy later on because oh, my problem remains the same. If the AHI has gone down and the patient is not happy with the surgery, he'll anyway remain unhappy. So now, therefore, that Kenny Pang and Brian Rottenberg, they have come with a sleep goal criteria
Mm.
in 2016. That AHI is only one of the criteria. One is the sleepiness, his quality of life. Is the patient less sleepy now? Is the patient more rested now? His snoring has gone down. His BP has gone down. The sleep goal criteria, snoring sound, a lot of things. So, a lot of parameters, not only AHI. So we always do the sleep study. It's not that we do not do the sleep study, but we do not give it too much of importance. If the patient is saying, I'm very, very happy, there's no snoring sound, there's no choking, then I say that it's your choice. If you want to do this sleep study, you do the sleep study. If you do not want to do the sleep study, I'm fine. But if somebody is not doing well, 100% I'll do a sleep study. I'll do a sleep endoscopy and see what is why it has not improved. And there are 5 to 10% of the patients who do not do well after surgery. And we repeat the sleep study and figure out what is wrong. 3 to 6 months is the time after which you do not do the sleep study again after 1 month of sleep surgery. Wait for at least 3 months. 3 months is a good time. Between 3 to 6 months, any time that the patient can do it is a good time for sleep study. Sleep after this surgery.
So one question is there any grading system that combines apnea graph and sleep endoscopy, so that we can plan, we can have a
Yeah,
definitive flow?
yeah. So I think sleep endoscopy. I started doing both in 2009 or 10 maybe, but I stopped using apnea graph because it's more invasive. Sleep endoscopy you do under in the see apnea graph you put in to the patient in the night and natural sleep. That is the advantage that you do it under natural sleep. But then there's a catheter which goes inside, and the apnea graph, Dr. Magnetoinirim, there's a cost attached every time. There's a big cost attached to the catheter. Now it's a disposable catheter. Earlier it was a reusable catheter. So disposable catheter, the cost is very high. In that cost, we can easily do drug-induced sleep endoscopy. And if you do sleep endoscopy, you think in much more